Good morning to all of you. Thank you, Harish, sir, for the kind introduction, and thank you, organizers, for this opportunity. So my talk is a very simple topic regarding insulin glargine, the insulin glargine enigma, unveiling the unknown session. So we know that world is celebrating 103 years of insulin, and if you see the insulin journey, we know that there are prototype insulin which is available previously. Now we are living in the era of biosimilar insulins. For the past 2 decades, we know that at least from 2010 onwards, we are having biosimilar long-acting as well as biosimilar short-acting or rapid-acting analog insulins in the market. So today's the talk is basically concentrating on the biosimilar long-acting insulins. And we know that more than 50 lakhs Indians are on insulin therapy, and these are some of the epidemiological aspects that all of us know regarding the diabetes mellitus. It is increasing worldwide, and 3 in 4 adult diabetes mellitus are living in low and middle income countries also, which is increasing the burden of managing diabetes in this region as well. And if you see the IVF data also, we know that 50% of diabetes mellitus are undiagnosed, and it is diagnosed only by investigations. And if you see the challenge again, we know that 50% of them are undiagnosed, and if you see that the HbA1c control, only 25% of them are having controlled HbA1c and 75% uncontrolled diabetes mellitus. And the sad state of affairs is only 15% of the patients are on insulin despite of poor glycemic control, and only 1/3 of the patients who are in the OID treatment with uncontrolled HbA1c is still willing to take insulin only by 35% in them. So there is an improper insulinization in these patients as well, and the poor glycemic control, which is contributing towards the complications, can be dealt with insulin initiation. So this is again a study which is showing the delayed insulin initiation in patients with type 2 diabetes mellitus. We know that we are having around 75% of the patients with uncontrolled diabetes mellitus if you see total of them. And if you see the data from the Initiate study, so insulin initiation is delayed by approximately 9 years in patients who are having an HbA1c which is more than 9% or 8% or more. And if you see the HbA1c at the time of initiation, it is almost 10.5%. So patients are spending sufficient or longer time in hyperglycemia, which is contributing towards the complications of diabetes as well. And we know that there are common barriers to insulin initiation. There are physician as well as healthcare system level barriers as well as patient level barriers. So if you talk about the patient level barriers, the most important thing is the needle phobia or the fear of injecting itself or unwillingness to inject itself. So then there are multiple other concerns like a lack of caregiver, then the cost of insulin, whether it produces hypoglycemia as well as weight gain, and all other mental thought blocks regarding the insulin therapy use. So from the physician point of view, the most important barrier for insulin initiation is the lack of time to educate patients regarding the need of insulin as well as the technique to use insulin as well as titration, etc. So this is the main thing even we also face in our clinics to start insulin. So understand that you are having a proper diabetic educator or a good team to support you, the initiation of insulin will be difficult in the clinical practice. So not only initiation is important, you have to give some contact numbers or follow-up opportunity for the patients who are started on insulin. You cannot start and say goodbye to them. So if you see the recommendation regarding the starting of insulin by different agencies, you can start with a basal insulin alone, or you can use a basal or a premix insulin or a co-formulation depending upon the scenario, like a fasting plasma glucose, a pre-meal blood sugar value, post-meal blood sugar value, age of the patient as well as the complexity of diabetes mellitus. So the basic thing or the principle behind starting a basal insulin as a insulin initiation therapy in a patient diabetes mellitus, first of all we know that basal insulin is a simple insulin, one-time insulin, and it is having less fluctuation with respect to insulin concentration also. So if you can see this graph which is showing an uncontrolled blood sugar value in a patient who is having diabetes mellitus, and you can see this high blood sugar value. If you give a basal insulin, what is happening is it is cutting down the fasting plasma glucose first. So it is coming, it is bringing down the insulin profile or the blood sugar profile as a whole towards the lower side. So the time in the target range will improve. So this is the fixed fasting first phenomenon. So if you see that whether starting insulin itself will control the blood sugar, No, I should say no, because starting of insulin is it should be accompanied by the titration of insulin as well. So if you see the percentage of patients who achieve target HbA1c of less than 7%, who are using insulin, it's only 32%. Why it is so? Because you can see from the data, the clinical trials used at basic insulin average value 40 units, but in the real world setting, the data shows that it's only 27 units. So there is a 13 units difference between the real world setting as well as the clinical trial setting, which indicates that when you start the patients on basal insulin, it is not getting titrated. That is contributing towards the uncontrolled HbA1c as well. So there are ways to titrate the insulin. So either you can empower your patient to titrate the insulin, that would be a very good option, or yourself you can control or titrate the insulin. It's called the physician-led versus the patient-led titration. So generally, when we see the data, it is also an eye-opener for us. We should empower our patients to titrate the insulin, to teach them how to titrate the insulin. So when the patients are leading the titration, the HbA1c is coming down better, and the blood sugar, fasting blood sugar is also coming down better. So take some time to educate your patient to titrate the insulin. That will bring down the HbA1c very nicely. So this titration basically happens in the first 2 weeks of insulin initiation itself. So it is important to have a follow-up visit in the first 2 weeks of therapy or starting the insulin, at least either through a telephonic communication or through a WhatsApp or through a video consultation or a physical consultation to address the issues. Otherwise, the titration will not happen. So this is one of the simple examples how to titrate the insulin level. So you can see that target blood sugar value kept it as 90 to 110 or 120 depending upon your convenience. So you can have 1 unit, 2 unit or 4 unit increment in the insulin titration depending upon the blood sugar value. And if the blood sugar, generally we tell them if the blood sugar value is less than 90, you can reduce 2 units of basal insulin. Or if it is less than 7, you can reduce 20%. And more than 40%, consult your doctor or reduce the dose by 40%. So this is an approximate titration regime, but you can use your own depending upon the clinical experience. So starting titration, and the third is the adherence. So if you are starting the patient on insulin, the most important thing is the adherence with the insulin therapy. So 1 in 4 patients with type 2 diabetes who are started on insulin will discontinue insulin within the 6 months, and the maximum discontinuation happens in the first 3 months. That is, the first 3 months is important for the follow-up of the patient also. So you ask them what are the concerns, why do you want to stop insulin, so how can you can overcome that. So if you do that in the first 3 months of therapy or starting the insulin, majority of the patients will be having good adherence, which will improve the HbA1c. Now come to the basal insulin glargine, whether it is safe to be used in patients who are having high risk like cardiovascular disease. The origin trial which was published in NEGM. So you can see the data, you can see the cardiovascular endpoints, and there is no hazardous or there is no increase in the hazard ratio of using glargine versus standard of care in patients who are having multiple risk factors. So you can trust this insulin to be used in any of the patients who are having cardiovascular disease or any renal disease or angina. So you can see it is one of the standard of therapy for the management of patients with diabetes mellitus who are having complications as well. So now coming to the biosimilar. What is a biosimilar? There are different definitions by biosimilar insulin by European Medical Agency, US FDA, and WHO as well as DCGI. Basically, a biosimilar is a biological medicinal product that contains the version of active substance with respect to the reference medicinal product in established scenario. The most important thing is the quality, biological activity, and safety and efficacy. So, if you are using a biosimilar insulin, it should be provided these parameters. So depending upon the biosimilar insulin, they have to undergo the PK/PD trials as well as the safety and efficacy trials. So there are two terminologies here, the switching as well as the interchangeability. Switching is nothing. If a doctor wanted to prescribe another insulin or another biosimilar product with respect to reference product, the physician can change that. So switching is common everywhere. So interchangeability means, I should say, US FDA mandate, because when you are prescribing an insulin, the pharmacist at the level of dispensing can change the insulin to another insulin, which is called an interchangeable biosimilar insulin. So it indicates one step ahead of the usual switching. That means the quality as well as the safety of that molecule should be more trusted as compared to the reference product. So interchangeable biosimilar insulin means a step ahead of the biosimilar in terms of its trust. So that's the thing. So whether all biosimilars are interchangeable? So a biosimilar cannot be substituted with its reference product without approval of the prescriber unless it is classified as interchangeable by US FDA. For the US FDA to make it as interchangeable biosimilar insulin, they have to submit additional data in terms of their safety and efficacy. So this is the thing that you have to understand regarding the biosimilar as well as interchangeability. Now, why we need a biosimilar? The most important thing why we need a biosimilar, we know that majority of the treatments like a cancer treatment or any other infectious treatment or a diabetic treatment is costly. So how to do the cost cutting? So why biosimilar is important is it is providing the 3 A's of things like affordability, availability as well as accessibility. So by using biosimilar, what we are expecting is to reduce the healthcare cost basically. So by after introduction of the biosimilar insulin, there is a significant reduction in the healthcare cost also. So these are some of the data which shows that the biosimilar insulin interchangeable glargine with respect to compared to the comparator insulin Lantus, it is safe, efficacious as well as no side effect as well from the various studies. So INSTRIDE trial is the trial which was done by the biosimilar glargine versus the Lantus in type 1 diabetes mellitus, and INSTRIDE 2 is the trial in type 2 diabetes mellitus. So type 1 and type 2 diabetes mellitus. So basically it is looking at the change in HbA1c baseline as well as the mean. You can see there is no significant difference in HbA1c level between the two insulins, and you can see the track of this HbA1c. And the next question is to bring down this level of HbA1c, whether both the insulins are actually the same doses. So the insulin dose is also same as in the INSTRIDE 1 trial. So in the INSTRIDE 2 trial, you can see here the HbA1c change over the time. It is almost similar between the two insulins, and you can see that insulin glargine dose is also similar between the two insulins. So total daily dose of insulin is almost same, and the HbA1c reduction is almost same, which indicates that the efficacy profiles are similar regardless of the previous insulin exposure. And in INSTRIDE 3 trial, this is again a switch trial. You can see here the patients who were in the INSTRIDE 1 trial who were using Lantus were again stratified into two arms like arm A and B. So they were given basal insulin, then again changed to Lantus and again changed to basal. This is type 1 diabetes mellitus. So they wanted to study the efficacy, safety as well as immunogenicity. So if you see the results, there is no significant change in HbA1c from the baseline to the week 36 between the two insulins. So it is compared with respect to HbA1c, and you can see the anti-insulin antibody exposure or the positivity. You can see here the antibody levels from the different data. The percentage of anti-insulin antibody between the biosimilar and the reference product showed no significant difference. So that means when you are using a biosimilar insulin, it contains some of the abnormal or antigenic materials, it can produce antibodies against the insulin. So development of antibodies against the insulin can produce some amount of deleterious effect in the management. It can change the insulin dose, it can produce hypoglycemia or it can produce hyperglycemia as well. So anti-insulin antibody positivity by using a newer insulin means it is immunogenic, which is not the case here. So if you see the safety endpoint, anytime hypoglycemia or incidence, again this is showing that the overall insulin incidence of hypoglycemia is similar between the two insulins, and the antibody levels also almost similar without any significant p-value. So this is again the PKPD data of these two insulins, where they have compared the US insulin glargine, European insulin glargine as well as the biosimilar insulin glargine. So you can see here the pharmacokinetic data. So mean insulin level after a single injection is almost similar, and you can see here the CLAMP study regarding the glucose infusion rate between the three insulins is almost similar. So this is showing almost similar PKPD profile as the reference insulin. So from these three trials, what they have shown is that the mean change in HbA1c is almost similar, and the insulin dose is also almost similar, no hypoglycemia or nocturnal hypoglycemia. So you can use this insulin confidently in patients type 2 diabetes or type 1 diabetes mellitus. From these evidences, FDA must approve the first interchangeable biosimilar insulin product for the treatment of diabetes mellitus in 2021. It was the Baselog 1 of Biocon previously. So now, why they have approved this one as an interchangeable insulin? Because they have provided that it can provide patients with additional safe and high quality, potentially cost effective option for the treatment as well. So when you switch from a reference glargine insulin to an interchangeable insulin, there is no need for dose modification as well. So this is the data from the Indian study, the India switch study, where they have studied the patient type 2 diabetes mellitus who were titrated with glargine to control the blood sugar value initially. Then they were divided into baseload as well as insulin glargine. And you can see that at the end of the study period, the blood sugar values as well as the HbA1c, it was not significantly different between the two arms. So to summarize my presentation, early insulin initiation provides better glycemic control and reduces the risk of development of complications in the long run. So insulin initiation is the most important. So efficacy, safety and cost determines the type of insulin to be initiated in the patient. So when they are using a biosimilar insulin, there should be some cost effectiveness for the patient and it should be having a safety as well as efficacy. So interchangeable insulin further reduces the cost of therapy. By using a base insulin, what you can do in each pill itself is it can reduce the complication rate, but itself can reduce the cost of therapy as well. And there is no additional risk related to switching in terms of hypoglycemia, immunogenicity, and you have Indian data also which shows that both these insulin are similar in their clinical characteristics as well. Thank you for your patient listening. I'm stopping my presentation here.
Thank you, Dr.